Hello students, my name is Liz Attia and today's topic is beneficence. So principle-based ethics and beneficence. So we've talked previously about this principle. Beneficence is based on an altruistic model. So it's active well-doing, conduct aimed at the good and well-being of others. Beneficence requires practitioners to, above all, value curing, helping and healing. And at this point, I'd actually ask you to consider the Hippocratic Oath and to consider the impact there on the Hippocratic Oath on practitioners' obligations in terms of their ethical code. And this idea of above all curing, helping and healing, and considering whether in the 21st century within our limited resources and the operational constraints of healthcare service delivery and the ageing of the population more generally, whether this idea of beneficence has actually gone too far given the advances in medical science and technology. So at what point do we actually, or should we actually say, in the interests of actually well-doing, doing good, being altruistic, that in fact we don't cure and we don't help and we don't heal, and in fact we refrain from helping, curing or healing in the interests of actually doing good? Because I don't think we can assume that they're one and the same thing. So traditionally, beneficence is considered engaging in behaviour which benefits the patients, that it's that we need to be competent and recognise the limits of our competence in our practice. So this requires some self-reflection on behalf of the practitioner to know what their skill base is and to know what level of competence they have in the interest of their patient to make sure that in fact they are doing good. So it's not self-interest, but it's actually about the interest of what's good for their client or the patient. So depending upon your perspective there, as I mentioned in the first lecture, the idea of beneficence can either be focused on the individual or it can actually be focused more generally in terms of what's good for the society or the community or the family. So it can actually be either a narrow view, the micro view, or it can actually be more of a macro view, extending who the stakeholders are in the particular situation. So I guess at this point I'd ask you why you think altruism is often missing from modern medical culture. Is it those principles of justice and, you know, limited resources that I mentioned a few minutes ago that impacts on how health service delivery is actually practically implemented? In fact, some argue that it's been replaced with fiscal concerns to do with rationing scarce resources, whether it be in terms of the physical resources or just in fact time. Several textbooks argue that medical practitioners should be altruistic and put their patients before themselves. But I mean, does that happen in practice? Should it happen? Is that a reasonable expectation of care? Is the commodification, the commercialisation of health, is that in and of itself, does that make this idea of an altruistic medical culture impossible? You know, there is business and there is money to be made in health. So does that in fact work at odds with this idea of altruism in our modern medical culture? These are just food for thought questions which I would ask you in your readings to reflect on and in fact to consider in your tasks for this week. So just moving on then, paternalism is often viewed as involving beneficence, and paternalism can either be weak or strong depending upon the gradient. Weak paternalism involves beneficent action towards patients who are not involved in a position to make informed decisions themselves, and strong paternalism involves engaging beneficent actions, even if the patient is competent and disagrees with the action. So it's this idea of the level of intervention then and the level of substituted judgment which is made by the healthcare provider or professional in the interests of their patient. It's either completely, if they're incompetent to, or it's to disregard the will. So if a patient or a client actually says, no, I'm not happy to, then in fact it's done anyway. And interestingly, there are some examples of that in the tutorial case study booklet, particularly with the blood transfusion and the Jehovah's Witness, where in fact strong paternalism is evidenced by the healthcare providers involved, irrespective of the wishes of the patient. Thank you, students. That brings today's topic to an end.